Hello everyone, today's topic is on anterior abdominal wall. Anterior abdominal wall, it extends superiorly from the xiphoid process and the costal margins. So here is the image where we can see the muscles are cut to expose the extent of anterior abdominal wall with its bony prominences. So let's see first superior extent. It extends from the xiphoid process. So this is the xiphoid process. Which is the lower end of sternum, and on each side it extends superiorly up till the costal margins of 7th, 8th, 9th and 10th ribs. So we can see on each side 7th, 8th, 9th and 10th ribs forms the costal chondral junction to form a costal margin on superolateral aspect. And inferiorly, it extends till the iliac crest and it extends till the anterior superior iliac spine. So this is the anterior superior iliac spine. And it extends inferiorly till the pubic tubercle, pubic crest and pubic symphysis. So, pubic tubercle, pubic crest, so pubic symphysis. So this is the extent of anterior abdominal wall. So here is the sagittal section to show the layers of anterior abdominal wall. So structures forming superficial to deep. So there are 9 layers which forms the anterior abdominal wall. So the superficial most is the skin. Beneath the skin is the superficial fascia. The 2 layers of superficial fascia, fatty layer and membranous layer. And also it is formed by the external oblique muscle. External oblique muscle. Deep to external oblique muscle is internal oblique muscle. Deep to internal oblique muscle is the transversus abdominis muscle. And deep to the transversus abdominis muscle, periperitoneal adipose tissue or extraperitoneal adipose tissue. That is the and deep to the extraperitoneal adipose tissue is the areolar tissue and peritoneum. So peritoneum, to be specific, it is parietal peritoneum. So these are the layers forms the anterior abdominal wall. So here is the image. One side we can see all layers are cut. The other side with the intact skin we can see. So these are the different layers with skin, superficial fascia, and we can see the muscles, external oblique muscle, internal oblique muscle, transversus abdominis, and deep to which is the fascia transversalis. Deep to fascia transversalis is the extraperitoneal connective tissue or extraperitoneal tissue, and deep to extraperitoneal tissue is the parietal peritoneum and visceral peritoneum covering different organs in the abdomen. So coming to the skin is the largest organ of the human body, and skin is loosely attached to the underlying structures of the abdomen with the exception of umbilicus. So only at the site of umbilicus we see the skin is tightly adherent. Rest everywhere it is loosely attached to underneath structures. So where the skin is tethered firmly to the underlying tissue. So we can see it is tightly adherent only at the umbilicus, rest everywhere it is loosely attached. Langer's lines which are sometimes referred to as skin cleavage lines and are the series of lines drawn topographically across the human body. So across the abdomen, these Langer's lines are oriented in a predominantly transverse direction with a gentle curvature. So the lines you can see here, which are faintly seen, are the Langer's lines. So Langer's lines corresponds to natural orientation of collagen fibers in the dermis and usually lie parallel to underlying muscle fibers. Thus, the transverse incisions heals with a narrower and more cosmetic scar because they are parallel to Langer lines and have less tension, while the longitudinal or oblique incisions with which the transverse lines may heal with a broader scar. So to have a less scar, it is good to give a transverse incision in the abdomen. The next comes to the superficial fascia. The superficial fascia in the abdomen is again divided into two layers. So if the superficial layer of the superficial fascia is the fascia of Camper or Camper's fascia, which is a fatty layer. In men, the Camper's fascia continues over the penis and blends with the Scarpa's fascia and forms the superficial fascia of penis. And this fascia extends further on into the scrotum. So here we can see this is the fascia of Camper. Or Camper's fascia. So in men, we know that this Camper's fascia, it continues as the superficial fascia of the penis, and this fascia extends further on into the scrotum, and where it contains a smooth muscle fibers and becomes Darto's fascia. Deep to this fascia of Camper, there is a membranous layer called as Scarpa's fascia. So deep to this layer is the Scarpa's fascia. So Scarpa's fascia firmly attached to the linea alba. So this is the midline. Raphe is the linea alba, which extends above and below the umbilicus. So the Scarpa's fascia or membranous fascia So Scarpa's fascia or fascia of Scarpa, it is firmly attached to the linea alba and pubic symphysis and fuses with the fascia lata or the deep fascia of the thigh. So it firmly attaches here below to the pubic symphysis and further continues in the thigh as the deep fascia of the thigh, which is called as fascia lata, and it continues right below the inguinal ligament as fascia lata. Scarpa's fascia continues into the perineum to form superficial fascia of perineum called as Colles fascia. So in the perineum, the same Scarpa's fascia is termed as Colles fascia. In women, it continues into the labia majora and anterior perineum. So in women, it continues till the labia majora. The line of fusion of Scarpa's fascia, it passes over the Holden's line or the body of the pubis and margins of the pubic arch and posterior border of the perineal membrane and posterior edge of the urinogenital diaphragm. So along this line we see the fusion of Scarpa's fascia forming a Holden's line. Therefore, if male urethra is ruptured in perineum, the urine leaks out and collects first in the superficial perineal pouch and then onto the anterior abdominal wall inferior to the umbilicus in the superficial inguinal space. Muscle layers of anterior abdominal wall. There are 5 bilaterally paired muscles in the anterior abdominal wall. Out of these 5 muscles, 3 are flat. External oblique. So one side it is cut to show external oblique muscle. This is external oblique muscle, which is the most superficial muscle. Deep to external oblique muscle is internal oblique. Deeper to the internal oblique is transversus abdominis muscle. So these are the 3 paired flat muscles, and remaining 2 muscles are vertical muscles. They are rectus abdominis, so rectus abdominis muscle, it is covered by a sheath which is called as rectus sheath, and pyramidalis muscle. Pyramidalis muscle is present in the lower near the pubis, is the pyramidalis muscle, which is also a content of rectus sheath. So the rectus abdominis muscle is responsible for the abdominal wall flexion. So the forward flexion of the abdominal wall is due to rectus abdominis muscle. The oblique muscles provide the abdominal wall rotation. So side to side rotation of the abdominal wall is due to oblique muscles. Linea alba. Linea alba is the tendinous median line that extends from the xiphoid process to the pubic symphysis. So here this white line in the midline crossing the umbilicus is the linea alba, which extends from the xiphoid process till the pubic symphysis. It is defined as the fusion of aponeuroses of external oblique, internal oblique and transversus abdominis muscles. It maintains the abdominal musculature at the certain proximity to each other. So a defect in the upper linea alba can cause hernia, which is called as epigastric hernia. Umbilicus. The umbilicus is the most obvious feature of anterior abdominal wall. The position of umbilicus is variable. Usually in adults who are fit without pendulous abdomen, it lies at the level of lumbar vertebra 3rd and 4th, that is in between L3 and L4. So it lies between L3 and L4, that is the intervertebral disc between L3 and L4, and it indicates the level of dermatome T10. So it is supplied by thoracic 10th spinal segment. So the skin around the umbilicus is supplied by 10th spinal segment, thoracic 10th spinal segment. So therefore the visceral pain of appendicitis is referred to the umbilicus, and because the appendix is supplied by T10 spinal segment. And embryological remnants at the umbilicus, one is the ligamentum teres, which is the remnant of left umbilical vein, and 2 medial umbilical ligaments, which are the remnants of umbilical arteries, median umbilical ligament, which is the remnant of urachus or allantois. So these are the embryological remnants at the umbilicus. The next condition which is associated with the umbilicus is caput medusae. It is a pathognomic sign of portal hypertension characterized by the presence of engorged tortuous para-umbilical veins that radiate out from the umbilicus like spokes of a wheel, producing a clinical sign called as caput medusae. And this is mainly caused by portosystemic shunting of blood between the portal para-umbilical veins and systemic superficial epigastric veins. Obstruction of inferior vena cava is an uncommon cause of caput medusae. So that is due to portal hypertension leading to caput medusae. So the next important landmark is arcuate line or linea semicircularis or Douglas line. The inferior limit of posterior rectus sheath lies approximately 1/3 of the distance between the umbilicus and pubic symphysis. So between the umbilicus and pubic symphysis, the inferior limit, this line is the arcuate line. Which is otherwise called linea semicircularis or Douglas line. So here we can see the inferior epigastric vessels perforate the rectus abdominis. We can see the inferior epigastric vessels perforate the rectus abdominis at the level of arcuate line. Linea semilunaris, it is a curved line, vertical line on the anterior abdominal wall at the lateral edge of rectus abdominis muscle. So along the lateral edge of rectus abdominis muscle, if we draw a curved vertical line, is the linea semilunaris. So the herniation of intra-abdominal contents through linea semilunaris is known as 𝐒𝐵𝐺𝐼𝐻 hernia. Rectus sheath. Rectus sheath is formed by the fusion of aponeuroses, that is broad tendons of flat muscles like external oblique, internal oblique and transverse abdominis muscle, makes a sheath covering the rectus abdominis muscle called as rectus sheath. So here in this image we can see the anterior wall of rectus sheath on one side, and the other side represents the posterior wall of rectus sheath. So if the transverse section is taken above the arcuate line, the anterior layer of the rectus sheath composed of external oblique aponeuroses and anterior lamina of internal oblique aponeuroses. So here is the transverse section showing the rectus abdominis muscle, and here in midline is the linea alba. This is external oblique muscle, internal oblique muscle and transversus abdominis muscle. So if we trace the external oblique muscle, the aponeuroses of the external oblique muscle continues as the anterior wall of rectus sheath. So this is the anterior wall of rectus sheath. So not only the external oblique muscle, the anterior lamina of internal oblique muscle. So as we trace the internal oblique muscle, the aponeurosis, it splits into two layers, anterior and posterior lamina. So the anterior lamina of the internal oblique muscle forms the anterior wall of rectus sheath. Let's see the posterior wall. Posterior wall composed of transversus abdominis aponeurosis. So here is the transversus abdominis aponeurosis, which is continuous along the posterior wall, and also the posterior lamina of internal oblique aponeurosis. So the posterior lamina of internal oblique aponeurosis both together blend to form posterior wall of rectus sheath. So this is the composition of the rectus sheath above the arcuate line. If the transverse section is taken below the arcuate line, only the anterior layer of rectus sheath is present, which is composed of aponeuroses of external oblique, internal oblique and transversus abdominis. So here is the rectus abdominis muscle, and we can see the external oblique muscle, internal oblique muscle, transversus abdominis muscle. All three, the aponeuroses of all three muscles, they all blend to form the anterior wall of rectus sheath. Whereas posteriorly it is deficient. So posteriorly there is no posterior wall below the level of arcuate line. So let's see the composition of the rectus sheath at the level of arcuate line. So at the arcuate line, the transversus abdominis aponeuroses. So this external oblique. So transversus abdominis aponeuroses and the posterior lamina of internal oblique. So all of them, they blend along with the external oblique aponeuroses. So thus the lower 1/3 of the rectus muscle is in direct contact with the peritoneum. So we can see here, this is the peritoneum. So the rectus abdominis muscle is in direct contact with the peritoneum in the lower third of rectus abdominis muscle. So next we shall discuss about the transversalis fascia, which is a loose connective tissue holding the peritoneum to the abdominal muscle. The transversalis fascia is a weak fibrous layer covering the inner surface of the transversus abdominis muscle. So here is the transversus abdominis. So deep to the transverse abdominis muscle, the inner layer is the fascia transversalis. Which is otherwise called as transversalis fascia, and it is separated from the peritoneum by a layer of fat which is called as extraperitoneal connective tissue or preperitoneal fatty layer. So the next layer is the extraperitoneal tissue or layer. Between the transversalis fascia and the peritoneum is the extraperitoneal space, and it holds a layer of tissue of varying thickness that contain fat and connective tissue. So this tissue is named as extraperitoneal fascia or extracoelomic fascia or anterior to the peritoneum or preperitoneal fascia. So you can name it as extraperitoneal or preperitoneal or anterior to the peritoneum. So this one is the extraperitoneal connective tissue or extraperitoneal fascia. Retroinguinal space. The retroinguinal space is the space between the parietal peritoneum and fascia transversalis. This space can be used for putting a prosthesis when treating in inguinal hernia. So that is the importance of retroinguinal space. The next layer is the parietal peritoneum, which lines the peritoneal cavity. So you can see the parietal peritoneum covering the pelvic organs and also the abdominal organs. So the peritoneum is a single layer of serosa supported by a thin layer of connective tissue that lines the abdominal cavity. So that is about the parietal peritoneum, and 5 vertical folds are formed underlying the ligaments and the vessels that converge at the umbilicus. So this parietal peritoneum undergoes foldings, it folds itself to form the ligaments around the pelvic visceral organs. So the abdominal wall reflection of the bladder, which fuses with the urethus, forms a single midline umbilical ligament around the obliterated urethus, so which is called as median umbilical ligament. And there are paired medial umbilical ligaments, which are the remnants of obliterated umbilical arteries present on each side of median umbilical ligament or middle umbilical ligament. And lateral umbilical ligaments are associated with the deep inferior epigastric arteries. So lateral umbilical ligament is the fold of peritoneum which covers the deep inferior epigastric arteries. Neurovascular supply, blood supply. The blood vessels supplying the abdominal wall originate from internal thoracic arteries. So internal thoracic artery is here, which is a branch of subclavian artery descending down, that is from the first part of subclavian artery, and we can see the thoracic and lumbar intercostal arteries. So here are the thoracic and lumbar intercostal arteries, external and internal iliac arteries, and also the branches from femoral arteries. The superficial vasculature is located in the subcutaneous tissue and supplies the tissue superficial to external oblique aponeuroses. That is superficial to external oblique aponeuroses and also superficial to anterior rectus sheath. Whereas the muscles and the tissues below these layers are supplied by the deep vessels that are located in myofascial layers. So let us list out the deep arteries first. Inferior epigastric arteries. So here are the inferior epigastric vessels and superior epigastric arteries. Superior epigastric is a branch of internal thoracic artery and deep circumflex iliac arteries. So here is this one is the deep circumflex iliac artery, and also it is supplied by musculophrenic arteries. Musculophrenic arteries supply the diaphragm and same musculophrenic arteries also supply the deeper part of anterior abdominal wall. And let us list out the superficial arteries. So superficial epigastric or superficial inferior epigastric artery. So superficial epigastric and superficial inferior epigastric artery. Superficial inferior epigastric artery and superficial external pudendal. So here is the superficial external pudendal artery, superficial circumflex iliac, superficial circumflex iliac arteries. So these are the superficial branches. So all these are the branches of femoral artery. So if you see superficial inferior epigastric, superficial circumflex iliac and superficial external pudendal, all these are the branches of femoral artery which are given off in the femoral triangle. Inferior epigastric artery is thought to be dominant vascular supply of anterior abdominal wall and it branches from external iliac artery. So we can see here inferior epigastric artery, it is a branch of external iliac artery. Above to the inguinal ligament, we can see it is given off in the inguinal region. So inferior epigastric artery forms the lateral boundary of �𝐶𝐵𝐼𝐻 triangle. So this artery forms a lateral boundary of �𝐶𝐵𝐼𝐻 triangle which helps to distinguish between the direct and indirect inguinal hernia intraoperatively. So if it is indirect hernia, the hernial protrusion will be lateral to these epigastric vessels, that is inferior epigastric vessels. If it is a direct hernia, it lies medial to the inferior epigastric vessels. So that's how the surgeons will determine whether it is direct or indirect inguinal hernia. Next, regarding the superior epigastric artery, it is the terminal branch of internal thoracic artery. So superior epigastric, we can see it is a terminal branch of internal thoracic artery. The deep circumflex iliac arteries, also the branches of external iliac artery and less frequently from inferior epigastric. Sometimes it may get origin from inferior epigastric artery as well, but commonly it is a branch of external iliac artery. So we can see from the external iliac, deep circumflex iliac artery is given off. Musculophrenic artery is also a branch of internal thoracic. So here is the musculophrenic artery, which is a branch of internal thoracic artery. Venous drainage: above the umbilicus they drain into subclavian vessels, below the umbilicus they drain into external iliac vessels. The same name as the arteries, the veins also accompany. So above the umbilicus we can see the internal thoracic vein is there which drains into subclavian vessels, and below the umbilicus drains into external iliac vessels. Lymphatics: the lymphatics of the abdominal wall follow the course of abdominal veins. So the channels of the upper abdominal wall above the umbilicus drain primarily into anterior axillary nodes, while those below the umbilicus drain into inguinal nodes. So the transverse incision may disrupt the lymphatic drainage. Nerve supply of anterior abdominal wall: Anterior abdominal wall is innervated by 7th to 12th intercostal nerves which innervate the anterior abdominal wall. So 7th to 12th intercostal nerves. So these are 7th to 12th intercostal nerves. The 10th nerve supplies the region of umbilicus. So if you trace the 10th nerve, it supplies the region of umbilicus. Contributions from the nerves of lumbar plexus L3, L4, L5 including the iliohypogastric, ilioinguinal and genitofemoral nerve and lateral femoral cutaneous nerves. So lateral femoral cutaneous nerves of thigh which is present on the lateral side of the thigh, and apart from that this is the lateral cutaneous nerve, then iliohypogastric, ilioinguinal, and genital branch of genitofemoral nerve as well. And it is supplied by iliohypogastric. So these are the nerves contributions from the lumbar plexus, that is from with the root value of L2, L3, L4 supply the lower lateral part of the anterior abdominal wall. So the vertical incisions except at the midline can expected to lead to sensory impairment of inferior and the medial to the level of transected nerves. So points to ponder: most common vertical incision given in the anterior abdominal wall is the paramedian incision. The commonest site of abdominal hernias is the groin. The dartos layer of the wall of the scrotum contains a smooth muscle innervation of the body wall. So the smooth muscle contractor relaxes to help to maintain the temperature of the testis about 2 degrees below the body temperature. The abdominal muscles contract and relax with respiration, and the abdominal wall conforms to the volume of the abdominal viscera. There is an abdominothoracic rhythm. Normally during inspiration, when the sternum moves forward and the chest expands, the anterior abdominal wall also moves forward. If when chest expands, the anterior abdominal wall remains stationary or contracts inward. It is highly probable that the parietal peritoneum is inflamed and has caused a reflection contraction of abdominal muscles. The shape of the anterior abdominal wall depends on the tone of its muscles. A middle-aged woman with poor abdominal muscles who has been repeated pregnancies, who has had repeated multiple pregnancies, is often incapable of supporting her abdominal viscera. So the lower part of the anterior abdominal wall protrudes forward, and in this condition it is known as visceroptosis. So this completes the anterior abdominal wall with its anatomy. Thank you.